Stanford University.
Good evening. We'll begin, and I want to thank each of you for being here at the second event of the 2017 Contemplation by Design Summit. My name is Dr. Tia Rich, and I have the pleasure of coordinating and directing Contemplation by Design, and it is a great honor to be hosting this panel discussion with you this evening on compassion in healthcare. We have as our panelists the Dean of the School of Medicine, Dr. Lloyd Minor, if you'll just nod your head, and Dr. Charles Prober, who is the Vice Provost directing the new Health Education Center, Dr. Mickey Trockel, who is the Head of Research and Education for the Well MD Center, and Dr. Dale Beatty, who is the Doctor of Nursing Practice here at Stanford. We've prepared some questions for them to answer, and then we will move to an interactive Q&A session. We very much welcome your insights, your perspective as part of this conversation. We'll begin with just some background on Stanford. We're going to be focusing on the core question of what is compassion, and at Stanford Medicine, you've all seen the statement, the tagline that says, Stanford is healing humanity through science and compassion, one patient at a time. As we explore what compassion is and how it plays out in healthcare, I'll just invite you to consider the current understanding of compassion among emotion researchers. And they define compassion as the feeling that arises when you witness another's suffering, the feeling that motivates a subsequent desire to help, and the feeling that is expressed in actions of kindness and compassion. This definition differentiates from empathy, which refers to the vicarious experience of another's emotions. At Stanford, we have examples of compassion at the corporate level, the clinical level, and the experience among the care recipients. In our conversation, we are going to include all three dimensions of that in terms of how healing humanity through science and compassion, one patient at a time, takes shape and form in corporate policies, clinical practices, and care recipient experiences. If you go to the Stanford Medicine website, there's a beautiful timeline of various historic events. An early one that caught my attention was in 1962. For the first time, families were allowed to visit the neonatal unit. Relationship-based care is a core value at Stanford. It is taught to the students. It is embodied in the training of the nurses and the physicians, and it is lived in the relationships with the patients. We're going to look at how the nursing professional practice model of heart, honesty, excellence, advocacy, respect, teamwork, and compassion play out. We'll also talk a little bit about the wonderful initiative and leadership in precision health. And Stanford's new Center for Health Education that will benefit people worldwide is another vehicle and channel of opportunity to model and express compassion. The new groundbreaking initiative of the Well MD program is looking at how to sustain fulfillment, efficiency of practice, and a culture of well-being for physicians and all healthcare providers. Looking to the future of that timeline, we look forward to how the concept of compassion in healthcare will be a little mark on that legacy 20, 15, 10, and even a year from now as key innovations are realized. So our first question, each panelist will answer, what does compassion in healthcare mean to you? And in their answer, they'll consider what does the phrase healing humanity mean in concrete, daily, pragmatic terms? What policies, programs, or practices have they been in part of implementing or supporting that helps to support compassion? We'll begin with Dean Minor.
Well, thank you very much, Tia, and I want to thank you for organizing this panel and for your leadership of contemplation by design. You summarized it very well when you defined compassion in your opening remarks. I think there is the internal component to compassion, and that is how do we open ourselves up to be receptive to the feelings and the needs of others. And then there is compassion manifested in our behavior and in our relationships. I think that both can be and must be taught and nurtured, and I'm very pleased and honored to serve on the faculty and to lead in an organization that has so many dedicated faculty members dedicated towards increasing compassion and making sure that our medical students and other trainees are being led and taught in a way that encourages them to be compassionate healthcare providers. We'll hear more about that in just a moment from Dr. Prober, who is, in his previous role as Senior Associate Dean for Medical Education, championed a number of programs. One of those founded and led by Dr. Lars Osterberg called the Educators for Care program, CARE being an acronym for compassion, altruism, responsibility, and empathy. You know, there are so many things today that conspire against us being compassionate healthcare providers. I'm reminded of a study, a classic study done in the 1970s at Princeton, where a group of seminary students were taken to a room and they were told, you need to go to this next building to give a talk. For some of the students, they were told, take your time, your discussion doesn't begin for another 20 or 30 minutes. And for other students, they were told, you've got to hurry over there right now because they're waiting for you and it's already late. And then on the pathway leading from one building to the next, there was an actor who, when the student crossed the path between the buildings, was coughing and lying on the ground. And what was found is that for those students who were told, take your time, the vast majority of them stopped to find out, could they help? For those students who were told, you're behind, hurry over to the next building, only 10% did. And I fear that all too often in healthcare today, we're faced with that same dilemma because the demands on our time, the mechanics of practicing in healthcare today are so demanding and so time intensive that compassion can oftentimes be pushed into the background. And the only way we can get around that is, as educators, to make sure that we're constantly emphasizing the importance of compassion and the importance of not compromising our behavior as compassionate healthcare providers because of the other demands on our time. The other factor, in addition to those external demands on our time that we have to be aware of, is that to be compassionate, you have to first have a sense of self-worth, a sense of well-being in yourself in order for you to exemplify and demonstrate those traits in the care you provide for others. Here too, we have a lot of work to do in American medicine. It's alarming to me that by many metrics and standards and surveys, over 50% of physicians in America today are burned out. And this burnout is for sure affecting their ability to be the type of compassionate healthcare providers that we would all expect. So here too, I think there's an opportunity for us at Stanford to lead. We began the Well MD Center here several years ago. One of the first things that a group of faculty approached me about when I came here as dean was our need to address and to really lead in the area of physician wellness. We've done a lot. We recently recruited the first, we believe, wellness officer at an academic medical center, Tate Shannenfeld from Mayo, who's done some pioneering studies on physician wellness. We really want to demonstrate first through the activities and programs for our own physicians and healthcare providers, but then more broadly, what we do here, generalizing that across the country to address this problem of physician burnout, because when physicians are burned out, they're not going to be compassionate healthcare providers, nor are they going to be the types of members of healthcare teams that, when we hear from Dale in just a moment, we have to have in order. Compassion isn't just in one individual, it can't be. It has to be an entire team that's compassionate. And if there's one group in that team that isn't, then that's going to conspire across the team in terms of the ability to provide compassionate care.
Thank you for that inspiring description of the aspiration and the commitment and the plans as we go forward. I'd like to now move to Charles Prober and ask you to comment on the same questions.
Great. Thank you, Tia. And again, as Lloyd said, thank you very much for putting together this panel and for inviting me to be a member of the panel. I feel, as I said to my colleagues before we started, the odd man out in terms of compassion, expertise, but so bear with me because I am passionate about compassion, but if there's expertise to be had in compassion, I don't know what that looks like. I took your questions very literally and wrote them out.
Thank you.
Of course, so that I would respond to them. And the point that Lloyd just made about physicians needing to, and all health professionals, to take care of themselves and the WellMD program reminds me of what my late mother told me many, many times. She used the word charity rather than compassion, but she would say, Charles, charity, compassion begins at home. And I think that that is so true, that perhaps one has to first start by being charitable, compassionate to oneself, to those that are closest to you, and then to expand that circle of compassion to those that we are responsible for in our healthcare profession. I think that the foundation and the attitudes and the practice of healthcare providers around compassion, really that foundation begins to be laid early in training. So I will reflect, as Lloyd said, on some of the programs that are present for our medical students. Programs aside, I think that the compassion is learned by observed behavior, by seeing others whom you ultimately decide, I would like to be like that person, because I saw the way they interacted with their peer or with their student or with their patient. And I think as we inculcate our environment, as Lloyd said, with teams of compassionate people working together, that will beget more people who share that deep need and want to help others. I would say that the opposite of learning from good behavior would, of course, be learning from people who do not demonstrate compassion in their interactions with their peers, with their students, with their learners. I can't think of anything more destructive than having somebody talk to you about compassion who you might observe is not compassionate. We don't have that, I hope, at Stanford, but clearly learning by example is so critically important. So in answer to the first question, what does compassion in healthcare mean to me? It really means approaching ourselves with compassion, approaching our patients with compassion, but also all of those that surround us, our peers, our colleagues, our trainees. And as you said in the initial definition, differentiating compassion from empathy, with a desire to help them when we see them suffering, whether it's suffering in the classroom or whether it's suffering in the hospital or whether it's suffering in their professional development. So that's what compassion means to me, and how I would define compassion, and that compassion begets compassion. The second question that you asked was, I'll read the question, what does healing humanity in concrete daily terms mean to you? In concrete daily terms, what does healing humanity mean? That's a tough one. And I would say it is, simply stated, it is really treating each other again, our patients, our colleagues, our peers, our students with kindness, with thoughtfulness, and with respect, and that will imbue the environment with compassion. I was mentioning to Lloyd earlier in a bedside class that I do on Wednesdays, which is today. We're with some second-year medical students. I was in the pediatric intensive care unit talking to a 14-year-old young man who had been in a serious bicycle accident with his mother sitting beside him. And his mother said in words that I could not say nearly as well, and with emotion that so captured the students. She talked about how the team that she had been surrounded with in Packard had come to her, had listened to her concerns. It happened to be around issues about drugs to use for pain management, to ask her what her fears were, to explain their point of view in trying to deal with those fears and getting the child on the right medication for managing the pain. And she said with deep emotion, it was felt by the students, it was felt by me, this is why this hospital is special. I mean, it is making those connections. So it was really simple but profound to me an extent. The final question you asked in the first question was, what policies, programs, and practices have I been involved with in terms of supporting the development of compassion? And I'll start with the most trite, perhaps, and end with the one which is, to me, more impactful. So the trite one would be creating social rounds, where students and faculty can come together and just talk to each other outside of the classroom, outside of the hospital, and so small it might be, but such connections that it can create. The Office of Student Wellness, so there's the Be Well program that Lloyd mentioned too, and there's an Office of Student Wellness that Lloyd has supported the development of in the School of Medicine that focuses on the students' being from things like, we have a gym on the 4th floor of the medical school, which we do not have access to, but is for the students and their personal trainer, but to those sorts of programs, to yoga, to meditation, to listening to themselves, and the Office of Student Wellness tries to tend to the students' personal needs while their professional development moves forward. Another class that I'm involved with that has been very impactful to me in the area of compassion is called Managing Difficult Conversations. And I co-direct this class with a professor from the Graduate School of Business, a person named Irv Grousbeck, who theoretically should know nothing about healthcare, and he would admit he doesn't, and why should he know much about compassion? But as we go through these cases of end-of-life stories or how to have difficult conversations with patients and their family, Irv has taught me over the 10 years that we've conducted this course, the importance of, and this is the metaphor that he uses, but I think it's actually physically true, the importance of, instead of sitting across the table from a patient and telling them what's going on, walking around the table, sitting beside them, and leading them on their journey as they deal with their illness. He says many more things, but such an important concept to me. And then finally, what Lloyd referred to in terms of a program developed at the School of Medicine, and Lars, thank you for coming. I can't see if there's other educators for care in the group, but it illustrates to me what we need to do with bias about developing compassion in our learners. So Lars Osterberg is an internist who is a very compassionate human being in what he has done in general and specifically to the homeless community and many, many other things. I asked him to develop this program called Educators for Care, and the C is for compassion. And the program selects physicians who we believe live the life, walk the walk, talk the talk when dealing with their patients of compassion and empathy, of taking responsibility and being advocates. And they lead our students during their time in medical school by example and by teaching them. So the students see those who are walking the walk and teaching them all of these skills along the way. And they stay connected with those students all the way through their time in medical school. So that the deep belief and importance of compassion, hopefully, and I think they do, rub off on the students as they go through medicine and hopefully then become compassionate practitioners. So thank you for...
Charles, thank you for animating the concept of compassion through vivid narrative examples that model the behaviors of listening and relating and expressing that care to patients and students and to colleagues. Thank you very much. Mickey, Dr. Trockel, may you take the stage now with your response to the question.
Well, the study that Lloyd mentioned about people who were and weren't in a hurry and how that may have impacted their compassionate behavior or not reminded me of an experience I had 1 week ago today. I was walking up the hill in Manhattan, and I wasn't in a hurry. I was on the way to a talk where I was scheduled to talk about physician wellness to a group of healthcare executives. And as I went up the hill towards Central Park, I saw a gentleman who was struggling to get up the hill in his wheelchair. And he was struggling because one of his arms wasn't working right. And so he was trying to get up the hill going backwards, where he could propel one wheel with his good arm, and then with his opposing foot, create some kind of stability and a little bit of pushing motion to slowly inch himself backwards up the hill. And I think anybody, particularly those who aren't in a hurry, in their right mind would stop and ask this gentleman if he needed some help up the hill. And I was happy that I got to be that person this day. And he first refused my offer. He said, "I'm sure you're in a hurry, that you need to get to work." But then when I asked again, he accepted my help, and I was able to push him up the hill and get him safely to his bus stop. And the reason I'm telling you this story, in addition to the fact that Lloyd reminded me of it, is that the way he thanked me reminded me of what it means to me to be a doctor. I kid you not, when he thanked me, he said, "Thank you, doctor." And I was dressed in this exact outfit in Manhattan. I think I looked like any businessman in Manhattan, but clearly this gentleman believed that doctors are people who want to help. Vivek Murthy, our recent Surgeon General, spoke to us a couple weeks ago at our inaugural American Conference for Physician Health. Lloyd was there, and other people, several people from Stanford were there helping with the conference and speaking. And I remember Dr. Murthy said that physicians are people who respond to a calling. I think he's spot on. Physicians are people who respond to a calling to become instruments of healing, instruments of compassion. And everything of any value in healthcare, all the technology, all of the organization, everything we do of any import is squarely to help clinicians be better, be more effective instruments of compassion and healing. So as I think about the concrete daily terms of what healing means to me, healing people, healing humanity, I think about that in terms of individual one-on-one interactions and organizational cultural factors. On the individual, one person at a time level, it means being present, noticing that one person's suffering, and taking active steps to alleviate that suffering. And on an organizational and collective level, it means working together to create a culture of compassion and kindness, and creating public discourse that establishes compassion as a normative expectation and also becomes a standard against which we measure and choose organizational and political leaders. And I think about my experience at Stanford. I remember as I was thinking about going elsewhere, I had an attractive academic offer to join another faculty. And as I was talking with my department head about my fit here versus opportunities elsewhere, she said to me, "Stanford is a special place, and you belong here." And I remember just that feeling of feeling cared for, wanted, loved. That's what kept me here. It was that conversation that led me to want to stay here and be involved in all the things that are happening here. And several have already been mentioned. And I've had the privilege of playing at least a small role in a few of them. I got to serve with Lars as an, especially for care, faculty member for the medical students before taking on roles that led me to need to let that go to do some other things with the WellMD Center. I think perhaps the opportunities that have been the most meaningful or provided the most meaningful minutes to me have been through a program we've established called the WellConnect program, which is a service that gets rapid mental health consultation and when needed treatment for resident physicians. There's something about being able to be part of the healing for one of my younger brothers or sisters in medicine that feels like it has a powerful multiplying effect, because I know if I'm able to help one of them heal from distress that might otherwise get in their way, that they'll be more effective instruments in healing when they deliver care for their patients. So that's probably been the most meaningful.
Mickey, thank you for illuminating this circle, this family of compassion, where the giving to another reanimates it in ourselves, and your examples really brought that to life. Thank you. Dale, Dr. Beatty, please share your experience of your response to the questions.
Sure. When I think about the notion, when you ask about compassion in healthcare today, I think about it used to be thought of as something nice to do, but it really is an emerging science, and we know that now. We'll be talking about some of the evidence later in terms of why that really is. And Tia, you talked about when we talk about the construct of compassion, the differences between that being very different from empathy. But it also, when you think about it, compassion is a complex construct that not only includes empathy, but it includes sensitivity. It includes being open to diversity and different thoughts and ideas, sexual orientation, all over different notions associated with the patient and the family and the people that we interact with on a day-to-day basis. So it's really important that we look at it. And Dean Minor mentioned the notion of burnout in the earlier portion of it. And one of the things that I see in healthcare that happens is if you approach interactions with empathy on a regular basis, you will find yourself being burnt out. Mm-hmm. You will find yourself being burnt out. You have to find ways to connect at a different level. And what I see sometimes with healthcare providers, with my physician colleagues and nurses and other clinicians, is they get caught up into the task and they get caught up in the empathy, but they're not connecting necessarily at a compassionate level. And if you're not connecting, that's where the meaning, your story was very meaningful, because that's really where people get energy back, is when they're connecting at that level and they're feeling like they're making a difference. And I do think people come into this business with a notion of providing service and providing compassion and healing on a regular basis, but helping people to understand how they do that through both the science and the art of what we do is really critical in our work moving forward. And I would just say, in terms of the issue of humanity, you mentioned the question of presence. I mean, presence, we'll talk a little bit more about that later, I'm sure, through our discussion, but presence is really important to make yourself available so that you can understand the suffering that someone is going through, being available and hearing what they're going through, both from a patient, family perspective, or even a professional colleague. That's really, really critical for the way that we work moving forward. So I would add those as additional comments.
Thank you very much. Well, I thank you all for your compassion to the community in being here tonight and having prepared your answers to these questions and continuing this discussion. We'll move to the next question, which is this question I'll direct to Dr. Trockel. Why is compassion a core value at Stanford? Describe evidence that supports the merits of compassion in healthcare.
Okay. And I brought a note that I received from one of our administrative team members a couple days ago, right at the time I was thinking about the conversation that I'd be having with my colleagues and all of you. This note was from this person when she was looking at materials that were marketing materials for this conversation. And when she saw this, she wrote to me these words. She said, "Wow, "This looks so cool," followed by 6 exclamation marks. Then she wrote, "I love Dean Minor. I go to all his town halls. He is very progressive and really takes time to hear everyone. This adds to my well-being and happiness at work." So there we have, to me, one line of critical evidence that indeed compassion is a core value at Stanford, and there are many more. Whenever I open my eyes, I see these lines of evidence. The American Medical Association ethics state that a physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights. Now, compassion and technical competency are both essential components to optimal clinical care, and they're synergistic commodities. Compassion, in fact, motivates self-improvement. It motivates academic prowess, academic learning. It motivates mastery of exquisitely difficult clinical skills. It motivates discovery, advancement in medicine. And in turn, patients want, and rightly so, they want their physicians, their clinicians, to deliver competent clinical care with compassion. We don't yet have clinical trial evidence demonstrating that we can train clinicians to become better in being compassionate care deliverers, and then that training moves them in a way that we can measure improvements in patient care outcomes. We'll get there. We'll have those studies before too long, I believe, and I'm confident that several of those studies will be conducted or led right here at Stanford. As I'm thinking about the evidence that does exist, there is a lot of evidence that demonstrates that patients and their families consistently rank components of compassion as among their highest healthcare needs. Clearly, patients rate their own clinicians and their own experience with healthcare in general in terms of compassion. But perhaps the most convincing existing evidence for the value of compassion in healthcare can be found in observing what happens in its absence. We've already heard a little bit about the construct of burnout. Well, one of the constructs of burnout is depersonalization, and the Maslach burnout inventory measures depersonalization with items that assess service providers' interpersonal disengagement to the point of treating individuals more like inanimate objects than humans. And not surprisingly, physicians that are scoring high in that one aspect of depersonalization, often because they're pressed for time or because they've become so emotionally exhausted that they don't have the reserves or the self-compassion to do anything else. But when they're in that space, it's not surprising that the quality of the care they might deliver suffers. In one study that's very memorable to me, of 178 physician-patient pairs, physicians were asked to complete a Maslach burnout inventory. Their patients were asked to identify the physician who was responsible for their care during their hospital stay. And then after discharge from their hospital stay, they were asked to estimate how many days it took for them to fully recover following discharge from the hospital. And the results of this study were remarkable. The researchers found that for every one standard deviation increase in the physician's level of depersonalization burnout, the length of time that their patients estimated it took them to recover from their stay in the hospital, from the treatment they received, were increased by an average of 12 to 13 days. So even though we don't have clear randomized trial evidence to prove the positive, the inverse, we will soon, and there's ample evidence to demonstrate what happens in the absence of fully available present compassion in healthcare.
Thank you, Mickey. In the field of health promotion, we know that it has been easier to identify the causes of dis-ease than it is to quantify the merit of the preventive efforts and lifestyle behaviors. So we thank you for your groundbreaking effort to make solid evidence for the role of compassion to be the antidote to burnout, the prevention of burnout. Thank you. We'll now move back to hearing from each panelist, asking about a concept of what is the source of compassion. There's a lively debate as to whether it's inborn or it can be cultivated. Is it an innate human trait or does it need to be taught? Describe any examples of how compassion is sustained and cultivated at Stanford. And then how do you personally, if you're comfortable speaking about your personal lifestyle, how do you personally sustain your compassion? And the second question that flows naturally from that is, what is the role of self-compassion? And we'll begin again with Dr. Minor.
Thank you. I think compassion is innate, but I also think it has to be nurtured and taught. And I haven't met anyone in my life that I thought was incapable of being compassionate. I've met people, interacted with people, and I'd like to talk about a couple of examples in the response to this question where compassion has not been demonstrated, typically because there hasn't been the opportunity for self-renewal, or the external demands on time have made people so burned out that they don't behave in a compassionate way. I'd like to follow up on a point that Dale made about, and you did as well, Tia, about the difference between empathy and compassion. And one of the things I've really enjoyed these past several months is working with Professor Jane Shaw, Professor of Religious Studies and Dean of Religious Life at Stanford. Jane and I are offering a sophomore seminar in the winter quarter on empathy in literature and medicine. And one of the books we're going to use in the course is a book written by a psychology professor at Yale, Paul Bloom, called Against Empathy. I think that the title was intended there was a little bit of hyperbole intended in the title. But the point really is, as Dale pointed out, if one accepts the definition of empathy as being to put yourself in another person's shoes, if you really do constantly, and you don't have the opportunity, or you don't make the opportunity to renew yourself, then you're not going to be able to be compassionate. And I think what we're doing, and to come back to the theme of health and wellness, and one example that we've used a couple of times with our medical students, a book written by an alumna of our School of Medicine, MD, PhD alumna, Sherry Fink, who went on to become a writer and New York Times correspondent, and who won the Pulitzer Prize for her coverage in New Orleans post-Katrina. Subsequently wrote a book about that called 5 Days at Memorial. Many of you know the story that there were some horrific things that went on at Memorial Hospital in New Orleans post-Katrina. And one can interpret these as being acts of compassion, or as I think Sherry Fink argues persuasively in the book, acts of physicians who, because of their fatigue and because of this isolated community in those days when they were in many respects cut off from the rest of the world, made decisions that many would consider far outside of what the scope of decisions that physicians should be making. And so this common theme that if we're not renewing ourselves, and this is going to get to the answer to your question, if each of us doesn't have a plan for self-renewal and really hold ourselves accountable, and collectively as a community hold the individuals in our community accountable for this self-renewal, then we're going to lapse into behaviors and into an ethos that doesn't reflect compassion. So what do I do for renewal? Well, I enjoy reading and really am impressed by writers who are great storytellers, and there's so many of them, and I find that I can immerse myself in a book and really gain a lot of personal renewal from that. Especially since moving to California, I've started exercising regularly, and that's made a big difference, and I'm really delighted that we afford a lot of opportunities here at Stanford for our students and our faculty through outstanding facilities for personal fitness. And that's become an important part of my life and my renewal. But I think the first step is really to acknowledge for each of us that we have to be intentional about planning our personal renewal, and we have to look for that in others and encourage others to do the same thing, because if we're not, if they're not, then it's going to break down what needs to be inside of each of us in order to be compassionate, no matter how much empathy we may have.
Thank you, Lloyd. What I hear is that in the aspiration to sustain compassion, there's inspiration from literature and perspiration by taking care of the body.
Well put. Very well stated.
Thank you. Charles, tell us what your...
Thank you, Tia. I like that, inspiration and perspiration. That was a wonderful summary of what Lloyd just said. So let me take as I looked at your question, of course I wrote it down because I wanted to be, again, responsive to your questions. I'll take the easy part. There were 5 parts to this question, too. One part was, is compassion innate or taught? So I thought I'd take the easy one first. And the answer to that is yes.
Thank you.
I think that there's probably, I think all of us benefit from having lessons of compassion reignite our compassion. And I think that every human being, I think, has the innate capability, and hopefully it's exercised often, of being compassionate. So I think it's both innate and taught, and I think it's mostly taught by observation, by example, by seeing compassionate events occur around us. The source of my compassion, I think it's innate and taught. I think that my early experiences from my family, and I quoted my mother right at the top of this comment about compassion beginning at home. I mean, I felt I had that modeling in a positive way, and I have many mentors and role models. And I would say of all the people that inspire my compassion, if I have compassion, it's the patients that I'm privileged to take care of as a pediatrician. And in fact, it's more typically the parents of the patients I'm taking care of, because some of my patients don't speak. They haven't learned to speak yet. But the parents, and interacting with parents and hearing them represent the needs of their child, and it's truly inspirational in the depth that parents will go for their children. You asked about some examples of how compassion is cultivated at Stanford. Mickey already gave part of the answer from one of his colleagues, which is set the tone from the top. Have town hall, you can't nod at that one. Have town halls where the leaders of the institution, whether it's the dean of the medical schools, the CEOs of the hospital, are really talking the talk, but also walking the walk. The programs that have been created at Stanford, we talked about E4C, Educators for Care, the CI Care program, which is, of course, in Stanford Hospital. I can't remember what the mnemonic stands for, but the expression is good, CI Care, and it's all about connecting to the patients and making them feel as comfortable as they can under the circumstances that they find themselves. And I think other examples at Stanford, the most profound ones for me, I've sort of already said, which is daily interactions with colleagues, with students, and with those patients and their parents. Sustaining compassion. I also like to read, and I also like to exercise. So I'll go with the inspiration and perspiration as well. But I think it's sustained by virtue of just seeing people around me who really do inspire me in terms of what they do on behalf of their colleagues, their peers, and most importantly, perhaps their patients. Because you gave me positive feedback on the story that I told, Tia, I'd like to read you something and then I'll stop. This was submitted to me many years ago about one of our medical students who had just finished his rotation in obstetrics and gynecology, his clinical rotation. And this was an unsolicited email that illustrates, at least in my mind, what true compassion is like. This third-year fellow at Stanford wrote about this particular medical student who had just spent 2 weeks with us on the gynecology-oncology service. Shortly after his rotation was over, I learned that he had decided to pursue a career in pediatrics. That's a win for us. While selfishly wishing he had chosen gynecology-oncology, I was so impressed with his performance on our rotation, I'd like to do everything possible to help him achieve his career goals. She then goes on, this person goes on to write, to put it simply, most outstanding medical student I've had the pleasure of working with, demonstrates some professional qualities that she underscores, but then she said it's his connection to patients which really made him special in her mind. Every day he met patients facing tremendous hardship and even death, and he skillfully forged relationships that were meaningful to both him and the patients, even under these circumstances. The most striking example was a young woman on our service with a rapidly progressive, undifferentiated uterine sarcoma. He helped care for this patient during her initial postoperative course, as well as during readmissions for complication of her disease. During these admissions, he developed an amazing connection with this patient, taking the time to visit with her at the end of each long day to listen and to offer comfort. After he rotated off service, he asked regularly how she was doing, and when she was ultimately readmitted with disease progression and chose comfort care, he was present again for this patient. Even though he had long moved on to other rotations, he carved time out of his day to visit with her before she passed. As a final testament to the impact he had on this young patient, he was asked by her family to speak at her memorial. There he delivered an eloquent and respectful perspective on his brief time getting to know this remarkable patient. It was clear to me then that they each had an equally important impact on each other. It's inspirational interactions like that that fuel me every day in recognizing the impact that we can have on each other through compassionate approaches in those interactions. Thank you, Tia.
Thank you for sharing another moving story. I hear that you're highlighting how an innate trait, when it is cultivated and tended and given light and warmth, it can thrive and be expressed. The other point that really stands out is how, in the absence of experiencing and receiving relationship and compassionate response to yourself, it can lie dormant. And so your emphasis on the exchange is really notable. Thank you. Dr. Trockel, please take us further into our exploration.
I'm thinking about the difference between empathy and compassion. And I'm hoping that we don't misunderstand the evidence that I think is available. I think it's absolutely true that empathy alone can lead to a lot of distress. The brain centers that register the suffering of others are the same brain centers that register suffering of self, one's own suffering. And so just sitting in empathy, particularly when that empathy is followed by a fear response, certainly can lead to exhaustion and distress. And yet, empathy, I believe, from my study of the literature and experience, is a prerequisite for real compassion.
Yeah.
It's that connection that Dr. Prober so well communicated through that story of this medical student. That's an essential part of the most meaningful clinician-patient interactions. I think that the difference between the empathy reaction that leads to distress and compassion is simply love. That when we love the person that we're feeling empathetic towards and actually want to alleviate their suffering, that then different brain centers are recruited. The neural circuitry that relates to love and the affiliation and all of the cascade of pleasant emotions that are part of that become an added component of the experience. So empathy is a prerequisite, and when we take it to the active wish to help, and particularly when we're taking active steps to help, then the experience becomes very positive. And in fact, there is literature to demonstrate that people can be trained to improve their capacity to care for others with compassion, and that they are better able to be with people in their suffering when they are cultivating that capacity. And as I prepared for this conversation, I thought it would be fun to have at least one thing new. So I went to a research data set to address the issue we've been discussing of self-compassion. And it had a research data set of 250 physicians, most of them young physicians. And we asked these physicians to respond to a 4-item question on self-compassion and to complete several other instruments, including the Maslach burnout inventory and some measures of similar constructs that we've developed at Stanford. And what we found is that, what I found just yesterday as I ran this analysis, is that those who scored in the lowest half of self-compassion, I'll just read the items for the self-compassion scale, and I think it'd be more meaningful. So here are the items that we asked physicians to respond to that indicated self-compassion or failure of self-compassion. One is, when I made a mistake, I felt more self-condemnation than self-encouragement to learn from the experience. 2, I was less compassionate, and this is reflecting over the last 2 weeks. I was less compassionate with myself than I was with others. 3, I put off taking care of my own health due to time pressure. And 4, taking care of my needs seemed incompatible with taking care of my patient's needs. And those that scored the worst on those items, or had the most failure of self-compassion, were, on our measure, 4.9 times, or had 4.9 times the odds of scoring above a threshold we'd identified previously for a critical level of interpersonal disengagement, or had 3.2 times the odds of scoring above the traditional cutoff on the Maslach burnout inventory scale for depersonalization that I discussed earlier. So even in this one simple analysis, at least cross-sectionally, we seem to have another line of evidence that physicians, clinicians do indeed need to find ways to renew themselves, that self-compassion is a critical component for their capacity to be able to deliver ongoing, persistent, compassionate care to others. So as I think about what I'm doing in response, I think my own development in this area is a work in progress. Maybe that's one of the reasons I'm attracted to this research. Certainly connection with others, colleagues, family members, is a big part of my wellness. In my own life, my religious practice, I find is a source of development of compassion. And then I'm also motivated by evidence showing that specific practices will improve my capacity as a clinician. As a psychiatrist and psychotherapist, I know from really good evidence that practicing mindfulness meditation will make me more effective as a clinician. So I'm doing my best. I'm not consistent yet, but I practice today. I'm engaging in mindfulness meditation. Exercise is easy for me, but contemplative practices take a little bit more work. And I'm starting that habit, motivated squarely by evidence that doing so will help my patients.
Thank you very much. We'll move right to Dale.
Sure. Just to add to my colleagues here in terms of, I think I agree with in terms of, is it innate or taught? I agree that it is both in terms of from my own experience, but I think it's important to point out it's not a destination, it's a continuum, and we're constantly working within that continuum within self-care. So in listening to my colleagues in the perspiration aspect of what they do for self-care, I need to add that component of it in terms of, because I think it is important for us to also reflect along that continuum of how we are taking care of ourselves. But I do believe it is innate, but it can be nourished and grown within your professional career. But I also think sometimes it will wax and wane. It's something we have to be reflective of and work on a regular basis. As it relates to sustainability, we're doing a lot of things at Stanford Health Care in terms of sustainability. You had mentioned our practice model up front with heart, with the C of compassion underneath it. Our practice model in the profession of nursing is based on compassion with the heart acronym above it. In addition to that, our philosophy within nursing within Stanford Health Care is built on the Dr. Jean Watson science of caring that was actually developed in the 1970s. And through that process, she's developed Caritas coaches that help individuals connect on a level so that they can connect with relationships that are meaningful and can provide compassionate care. And so we actually Stanford just sponsored last week a kind of international conference where we had folks coming in from all over the world to participate, and we had some of our physician colleagues there too. I want to shout out to Dr. Crow, who's one of our ops OBs there. She's a coach also, a Caritas coach, has exceptional scores in terms of patient experience and relationship. She's learned how to connect with people at a level to make a difference. So I think that is very important that we put super trainers, so to speak, people that can help coach and mentor other people along the way to help with that continuum of how we're doing nature versus nurture in our work as it relates to compassion. The mention of CI Care is an infrastructure that we have within Stanford Health Care to help people with the tools of communication and relationships, so there's better active listening and responsiveness to meet the needs of our patients and families within Stanford Health Care. So those are some very important things. For me, and personally, the things that I do in terms of to promote compassion is the notion of self-reflection, meditation as well. I also actively work with mentors and coaches of my own to get different perspective and ideas of how I could grow and develop as an individual. And I find that very rewarding and from a personal and professional growth experience.
Thank you. I'm hearing how the deepening of awareness, whether we call it mindfulness or reflection or empathy, deep awareness of another's experience is fundamental to the quality of living compassionately. We're going to move to questions now, as I know some of you are eager to get to ask the panel your question. And please just stand up to indicate that you'd like to ask a question, and we have an individual who will bring a mic to you. There was one other set of questions that I was going to give Dr. Minor an opportunity to answer, but I think in the interest of your participation, we'll move right to questions and answers. Is there someone who would like to initiate, or shall we go to the planned question? We have a gentleman here.
Yeah, it's Lars Osterberg. And a question for the panel is, one thing I haven't heard is about the environment. Clearly, we see our students and our trainees going to an environment of healthcare that's very challenging and even toxic. We talk about a lot of programs that we do to help them through that. But we also know that these students come into training with high levels of compassion, high empathy, yet we see it decline. We see it decline through medical school and through residency. What are we doing to help the healthcare environment so that this doesn't happen? I have to believe it's the environment, and I'd like to hear what the panel has to say about that.
I'm going to let you each decide who wants to go first.
I can start from the nursing perspective. On the nursing side of it, we actually participate in a survey process called the National Database for Nursing Quality Indicators, and it basically looks at the practice environment. So we get strong feedback from nurses and other clinicians in terms of how we're doing in that practice environment and where we have opportunities. We're recently, actually now we're in the midst of doing an organizational culture of safety, quality and safety that goes out organizationally to residents, physicians, and all staff to participate about what is happening in the practice environment from a quality, patient safety perspective. And that we use that survey data to figure out an action plan about where we have opportunities to skill build, where we have an opportunity to improve our resource, and where we have an opportunity to enhance the practice environment so that we can mitigate some of the challenges or issues that you're talking about.
I'm going to just note that the prepared question was exactly the question you asked. So thank you. We can continue.
Sure. I think the environment can be looked at in two respects, or two elements to the environment. One is the environment in which we live and work every day. So there, I think one of the things that we're trying to address is lowering the hassle factor associated with the practice of medicine. And certainly high up on the list of things that add to the pain and chores of practicing medicine without necessarily, at least in a perceived way, adding to the real value of the care we're providing is the electronic health record, the electronic medical record. And this has been a concern of ours for a number of years. I'm very encouraged that now we're actually seeing a good amount of attention focused on either building new front ends to the EMR or looking at new ways of documentation. And we will, in June of next year, sponsor a national conference on the electronic health record to bring together policy experts, entrepreneurs, as well as the leaders of the two major EMR companies to really focus attention on that. I've written quite a bit about it, and my op-ed in Courts from about a month ago, I got more responses to that, overwhelmingly favorable in terms of my attempt to shine a spotlight on it than I think of anything else I've written or talked about in a public arena. So that's one thing on the, shall we say, on the more focused microenvironment of the day-to-day interactions and practice of medicine. On a broader scale, I'm deeply concerned about the environment in our country today, the environment in which we live and work. I feel that very acutely from our students and our trainees, many of whom are personally affected or have friends or relatives personally affected by, for example, the decision to rescind DACA. And just the general attitude of intolerance in our country that manifests itself on a daily basis. And the fact that now between Twitter and what we can get online, we're in contact with these deep fracture lines in our society in ways that we've never necessarily been able to be in contact with them in the past. That for sure impacts the attitudes of the people in our community, the feelings of safety and well-being of our community, despite the fact that I think we are making every effort we can to be a diverse and inclusive community. It still is difficult in our country right now to draw home that message in a tangible way, given the deep fractures in our society today. That's going to be, I think, a much more difficult issue to address. It's not one that we singly or individually can address, but it's very important that we, as leaders at an institution that's looked at for its leadership, that we acknowledge that these problems exist in our society and that we're giving an opportunity for our community to come together to express our beliefs and to underscore our core values.
Anyone want to add to that response, or shall we open it up to another question?
Well, the only thing I'd say, but not, I mean, it was a wonderful response and certainly paints the picture. And Lars, you know it as well, or better than most of us, the complexity of the environment in which and you mentioned students and trainees train, and the multifactorial issues that are sometimes working against us. And I think that all that we can do, and it's a lot, is each of us take responsibility for that part which we have some control over in driving us towards that environment of that happy space. And it's not trite, as we all know. Kelly Skeff in the field of education, who's well known in the medical school, has made it very clear that one of the ways to enhance learning is to create a positive learning environment. That's in the simple stage of a classroom where you have more control over what's going on. Now, as Lloyd alluded to earlier, our students are not necessarily in the classroom. But the hospital classroom is a much more complex, complicated animal, from the electronic health record to the physical facilities to the multiple movements that are going on at any point in time. And it really requires looking at each of those individual items as individual items, but then looking to disrupt the whole environment. You know, to Clay Christensen's disruptive innovation, where you have to look at all of the component pieces and try to move them along together. As individuals, I think what we can do, and you do it so well, is to be in the moment with, whether it's our patient or our trainee or our student, to try to keep them tuned in to what really matters. Because we have some substantial problems. I would just keep it in the healthcare system. Lloyd took it to the country, which is the healthcare system on steroids, I guess, in terms of issues. But such an important issue.
I'm going to go a little deeper with the next prepared question, which just looks at how time and the issue of the speed with which patients are seen in most clinical settings, and also how reviews, rewards, and acknowledgments of people's contribution to the healthcare delivery are put into policy and practices that can support or diminish compassion. Specifically, in a performance review, in a promotion rating, is the person's compassion capacity included in the protocol? And in that, we'll then move to general conversation. But please share your thoughts on those specific examples of promotion requirements and time management in interaction. Tough ones, I know. I keep asking the real meat of the matter. I hope it's useful to everyone.
Well, let me just offer one example where we've tried to address the issue and concerns around time allocation. So our faculty who are primary care providers now are no longer held to an RVU-based standard. So relative value units are measures of the amount of care being provided. In procedurally based specialties, I think they have value. In primary care, they've actually contributed to the issue of physicians not being able to or rewarded for spending time with their patients. We still have a healthcare financing system, and I see that Professor Alan Antoven is here tonight, who has been such a leader for years at focusing a beacon on the problems with the way we finance healthcare in America. But there are inherent issues with the fee-for-service system that we really should be rewarding physicians based upon outcomes and improving health and measuring that in tangible ways and feeding that back into the reimbursement system. We're beginning to do that a little bit with bundled payments for things like joint replacements and certain cardiac surgeries, and obviously managed care organizations do that on a larger scale. But it's spotty in our healthcare delivery system today, and so we're always going to deal with this, as long as that's the case, with this misalignment of incentives. But what we're trying to do, back to your question, in our delivery system is beginning in primary care to say, look, we're going to set up some expectations based upon the amount of time we know you need to spend with your patients, and also we're going to furnish you with the advanced practice providers that enable everyone in the practice to practice at so-called top of their license. And that really increases I think the meaning that physicians, primary care physicians, get from the work that they're doing, rather than having to practice under the mantle of an RVU-driven system.
Thank you for those pragmatic examples. Very instructive. Other comments on this topic.
I would just add, Stanford Health Care is an ANCC, American Nurses Credentialing Center, magnet hospital. There's about 8% across the country of the 5,000 plus hospitals that are magnet designated. And what we know from that work, and there's been lots of research that's been done, particularly coming from Dr. Linda Aiken from the University of Pennsylvania, is that we know that outcomes, when rewards and recognitions are in place and through the magnet model, we know we do get better patient outcomes associated with, and so rewards and recognition are very important in the development of a healthy practice environment and people's perception of their own job enjoyment.
Thank you. Are there other questions from the audience? Gentleman in the red and the baseball cap, would you just stand, and the mic is coming your way? Thank you.
My name is Wen. I'm trying to figure out how is this sustainable in the large. I mean, I understand compassion and I understand how you guys practice. I have lots of physicians in the family. So how is this, and this is probably to you, sir, how is this sustainable in the future? I mean, fee-for-service is what it is, and HMOs have profits, and it's the age-old question, and how does this become sustainable in the large when, as the other gentleman said, I mean, my sisters and brother, they all have this sort of lack of compassion now in practice. And it's very difficult to sustain. So can you say something about sustainability of what you talk about here?
Thank you. Let's open that up for response.
Well, I think you've made some very important points, and there's a lot embedded within your observations and your question. They're very important points. So thank you for bringing them up and asking us to comment on them. The Affordable Care Act is not a perfect piece of legislation, but it did start a process of moving away from a strictly fee-for-service world and moving and providing incentives and then requirements for providers and healthcare delivery systems assuming risk or sharing risk with payers and enrollees and insurance plans. And until we close the loop and really start to reward and pay based upon outcomes and based upon value, with value being outcomes divided by cost, we're going to continue to have the types of problems that you described. I don't think that that being a physician in an HMO of necessity means that you're not going to be fulfilled, you're not going to have an opportunity to provide the care that drove you to go into medicine. There are some extraordinarily excellent, fulfilled, happy physicians practicing in organizations like Kaiser Permanente. And I think all of us can learn a lot from Kaiser. I also think that what we at Stanford offer, particularly, at least at the current time, in the tertiary quaternary care, is quite extraordinary. And the types of things we're seeing in improvement of cancer treatment outcomes with immunotherapy, for example, that are being pioneered here and at other academic medical centers would not necessarily happen in a world that was entirely dominated by HMOs that are focused on provision of the best care as we know it today. Because an important role for Stanford is to deliver that care as we know it today, but also be pioneering the care that defines the future. And that shouldn't just be restricted to the ultra-complex care. We should also be, and I think increasingly we are, pioneering in advances in primary care. And our vision of precision health is very much to predict, prevent, and cure precisely, but in that order, really focusing on prediction and prevention, where we're seeing some encouraging science that we can now bring to the bedside. So it's a combination of the misaligned economic incentives from the dominant reimbursement system in the country today. you know, you can have any business model, whether it's HMO or fee-for-service, and if it's poorly administered and poorly led, it won't be an organization that anyone wants to work for. But I don't think that comes from the model itself. So I don't think there's anything per se that says that working for an HMO is going to preclude you from a physician, us from physicians, from having a high degree of fulfillment and reward working in that system.
Out of respect of all of your time, especially our panelists, I want to end here by first thanking Dr. Trockel, Dr. Prober, Dr. Minor, and Dr. Beatty for sharing what they work hard at every day as their answers share and show us, and letting us see the groundbreaking work that they're doing to bring compassion into healthcare. Thank you very much.
Thank you.
Thank you so much.
Thanks, Vicky. It was great.